if we look at the tensions and dilemma when it comes to the structures involved, we can clearly see that there are elements lacking. It's the huge problem in today's world of vulnerability, social inequality as well, not just in health. Here we're talking more about problems related to health itself, and that's something that I think we will discuss today. Basically, we're confronted with a load of different suffering, whether it be physical or mental. Once again, the challenge is clearly one related to structures. So it's a very interesting roundtable. So before we get into the heart of the subject, we'll be looking, of course, we'll be hearing from people from the north and from the south. And I think it's going to be an interesting dialogue for us to have together. So without any further ado, let's listen from Alice Desclos, health anthropologist and research director at the IRD. So Alice has worked in a lot of places around the world, most notably in recent years in Western Africa, and also most particularly in Senegal. Alice, over to you. The interpreters cannot hear the speaker.
Pardon, où est-ce qu'il faut se diriger pour faire tourner les diapos? L'ordinateur au fond. Oh là là. Ça marche pas. Je peux, d'accord. Je voulais. Donc diapos, s'il vous plaît. Donc je vais on va voir ensemble.
Okay, let's get back to things. So the fact that these epidemic crises can also be opportunities for transformation. Most notably when we have a planetary impact, which enables us to mobilize actors and resources. But we're going to look at two key epidemics, very different profiles. First of all, the West African Ebola epidemic, 2013 to 16, pre-transition epidemic, we could call it. A lot of help was brought in to assist the existing health services which couldn't face the impact. It was just too big for them. That's the first one. The second one, we'll be looking at the COVID pandemic. And we use this slogan, building the boat while sailing, given the successive waves of COVID, which enabled us to improve our health system gradually. So these transformations, I'm going to look at them considering the response and the way the epidemic was dealt with, also the way the civil society were committed, and finally to look at the elements at stake. The interpreters are happy to be back in the meeting. So following the management of the epidemic of Ebola in Guinea, 2014, there was 4 months between the first case and the declaration of epidemic. Then 6 months were needed to ensure that international organizations put all their assistance in place with the treatment centers for Ebola to be put in place in a number of countries. We had a number of people who were sick and a number of people who died. So what happened following Ebola? We developed local diagnostic capacities. The virus itself. And there were treatment centers put in place. So these are permanent treatment centers put in place in the country. We also had national coordination centers put in place with experts, etc. What else? We also managed to develop skills and resources for the
Et puis la
epidemiology,
recherche
detection and monitoring, and
thérapeutique
finally, of
aussi
course, the
vaccinale
research
afin
on
d'évaluer ce qui a
vaccinations.
permis de continuer dans les épidémies
And
suivantes.
that enabled us
Pendant
to
la
be better
pandémie de
prepared for
Covid,
future
d'abord,
epidemics.
l'Institut
And then we had
hospitalier,
COVID. We
donc
had
ça a été
the
activé
development of
par le
Africa
gouvernement
CDC,
opérationnel,
which
comme
became fully
l'ICPC européen
operational,
et
just like the
américain,
European
qui
CDCs and
apporte
American
l'expertise régionale et
equivalents,
un soutien aux pays.
giving support
L'OMS a
to
dû se
the countries
redéployer
in
pour un
question.
niveau
The
plus opérationnel
OMS
en
was also
créant
redeployed.
deux plateformes de coordination qui
Two
sont
coordination
basées
platforms were
dans
put in
deux
place.
régions, qui sont
In
l'Afrique
two
du
different regions, we have the
centralisée à Dakar,
Central and
basée à Dakar, et l'Afrique de l'Est et du Sud basée
Central and
à
Eastern
Nairobi, vraiment
um,
plus proche de
center
réalités
in Nairobi, and the other one in
culturelles,
Dakar.
linguistiques et culturelles.
So this
Il y a eu
made
des
sense
stratégies de
linguistically and
reprise de
culturally as well. There was a
l'épidémie, des
certain
systèmes de soins.
strategy
Alors peut-être un des meilleurs exemples, c'est
concerning catching up
l'accès à
on
l'oxygène.
the
Pour le
shortcomings
Burkina Faso,
within the health
l'Égypte,
service center. For example, a
99
lack of
patients
oxygen.
qui passaient sont
Burkina Faso only
hospitalisés
had
et intraçables pendant
90
pandémie de
breathing
Covid.
units, and
Et ce qui a été
this was
aussi
of course
évident, c'est la prise
increased
de conscience
during
du
this
fossé
COVID
entre l'accès aux
pandemic.
traitements en Afrique et
Then
aux
this huge
vaccins
gap
dont ont été
that we
mis en
saw
place
between those who could
des
access the vaccinations and
dispositifs
those who
pour
couldn't in
fusionner
Africa.
recherche. Diapo. Alors, pour les
Next
sociétés
slide,
civiles, évidemment, les
please.
modes d'engagement dépendent du profil
So for
épidémiologique
civil societies, that
de
depends
l'épidémie
always on the
de
profile of
chaque
the
maladie. Pour
epidemic in
Ebola, on
question.
pourrait dire que la société
For
civile a été
Ebola, we could
sidérée
see
la
the
perte de
impact on civil
confiance, liée
society.
aussi à des
People were
interventions
very, very
des
scared.
autorités publiques parfois
Um,
violentes. Et autre aspect,
and
la
this led to
possibilité de
violent
mobilisation
confrontations
des
often.
acteurs communautaires en première
Also,
ligne pour
we have
rendre les
to
mesures de
underline
prévention et
the
de soins
key essential role of
accessibles aux
stakeholders in
acteurs
the
qui sont
communities who are
souvent
on the front line, often these
invisibles
people who are
et
often
protégés
invisible
par rapport au risque.
and very poorly
Alors,
protected
pandémie
against
de
the risk.
Covid,
That's for
la
Ebola.
société
For
civile s'est
COVID,
engagée à
civil
renouveler
society had
avec
a
son
number of
commitment
different forms of
à
mobilization,
l'activisme, même, on pourrait dire, dans cette
from
pandémie. Il
communities
y a eu
all the
une
way up to
extension et
activists.
une hybridation des
We
mobilisations
had a kind of
communautaires avec
extension
l'ensemble
and
de la diaspora
hybridization,
grâce aux nouvelles technologies
including
ou
the
avec des
diaspora,
décloisonnements entre
and also
associations
this
professionnelles et
um,
communautés.
bringing together of
Il y a eu
professionals
des
and
actions de
communities.
mobilisation face au sida,
Also, we
30 ans, 30
learned
ans,
a lot more
qui ont
thanks
en
to
effet
mobilizations
permis de
after the
protéger les
AIDS
patients avec
virus,
le VIH
enabling
et
those
le
who did
Ebola.
have HIV
Mais le modèle
to
de
be better protected
résilience
against COVID.
mis en place notamment par le Fonds mondial n'a pas été élargi
But
et
the
repris pour
OMS
traiter du Covid.
governance
Alors
model
l'OMS a aussi
didn't
évolué dans
really
son
live up to
discours.
what we were
Maintenant, elle
expecting.
soutient les mobilisations communautaires et la
Now they
co-construction des
do
stratégies de réponse.
support
Mais les
community
acteurs les
mobilizations,
précoces restent, on peut dire,
but
peu
the
reconnus
shortcoming is the
et
fact that
précaires.
those involved are still
Voilà
not
pour
very
les
well
priorités.
recognized and
Et
their
alors les
position is still
enjeux sont
very
des enjeux anciens,
precarious.
hein. Donc là je vais vraiment survoler les inégalités
Stakes.
de réponse, les conflits entre les
What
populations
challenges do we have here?
vulnérables, la
Well,
question de
the
l'équité,
inequality for
les
response,
insuffisances de services
the question of
sanitaires, et puis les effets
equity,
sociaux à moyen et long
the
terme
social
qui
effects,
sont
both
généralement peu
medium and
documentés
long
comme dans
term,
la
which are often
pandémie.
not very well
Alors
known.
les
We saw
nouveaux
that during the
enjeux, diapo
pandemic.
s'il vous plaît,
Next slide, please.
ils sont d'abord liés au
So,
changement
what are the
d'échelle.
future challenges? Well,
On a maintenant des
essentially connected
dispositifs
to
qui permettent
the new
d'avoir des
time
données
scale.
épidémiologiques sur
We need
le
to
nombre
have
de cas de décès
epidemic data
chaque
about
semaine dans
the
les
number
pays
of
qui sont
deaths, and this has to be
sensibilisés.
each week
Et donc,
in
on a une
each country.
information rapide à propos des
We need to
émergences
ensure we
et
have
ciblée. Ça
quick
permet
information coming out.
d'ajuster à peu près tous les 15 jours les
So
réponses
every
sur
15
place
days, we
aux
can
événements
adjust our
qui sont
response
émergents.
depending on the information that we have.
Par ailleurs, donc un turnover des stratégies qui peut être beaucoup plus fin et plus rapide.
The
Par ailleurs,
change of
nous avons
strategies is
tenté de
clear.
sortir du cycle panique
We
et
want to need to move
négligence
away
pour
from that
développer une
panic and neglect
préparation, donc
format
une
and
anticipation
develop
des
the
crises
anticipation format.
par des formations, la définition
This
des
is done through
procédures,
training,
la
defining
constitution des états
procedures,
d'urgence, les
creating
simulations
pre-positioned
et des
stocks,
formes de coordination
training simulations,
horizontale et verticale en
and both
amont et en
horizontal
aval.
and vertical
Il y a une
coordination programs
anticipation
upstream
précise à
of
mener
the
maintenant
epidemics.
pour les niveaux de risque nationaux. Et l'OMS vient d'annoncer qu'elle
The
allait
OMS has just announced that they
informer les
are,
pays 2 mois
or the
avant
World Health
l'émergence de
Organization,
l'épidémie
are
pour
able now
donner
to
cette
provide information
visibilité
2 months
sur les
beforehand so
facteurs
that
de risque
the different countries can
supplémentaires
be
qui sont
ready.
modélisés ou des épidémies récurrentes comme celle de choléra. Alors ceci grâce à toutes
This
sortes
could
de
be for
technologies
a
de
new
mesure
epidemic or something
industrielles
that's recurrent, for
et
example,
certainement
cholera.
artificielles pour capter des signaux
So
faibles.
thanks to AI,
Donc ça
we
veut
can
dire que la
really
préparation
recognize the signals
s'accompagne
and
d'un
to have
temps,
information 2 months in
le temps de
advance.
readiness, comme on dit,
We
et
have the
aussi
time
de
of readiness,
préparation pour se mobiliser.
which
C'est
is
plus
absolutely
important
vital. This is the term
dans
given
les
to those
opérationnels
2 months that
Alors, d'autres
are
enjeux
now
liés au
possible.
changement d'échelle
What other
sont
challenges connected on
l'accélération de
this
la diffusion
new
massive
time frame, new time
amène
scale?
à amener à se
Well,
focaliser
we could
sur la
see the
dimension
way that
régionale, celle de
epidemics
l'Afrique au sud de
spread
Sahel,
so
par
much
exemple,
quickly than
ou
before.
l'Afrique francophone, plutôt que des approches nationales ou nationalistes. Alors, il faut savoir que dans la région AOC, la
In the
coordination entre les
AOC
agences
region,
sous-attentes
the
essaie de
WHO
favoriser l'action de
coordination
liens
is
entre
working
les
together
actions
with
et recherches.
those who
C'est la
are
seule
working on
région
action and
atlantique.
research. Is the only place in the world
Alors,
where
tout
it
ça
actually
questionne
where we
vraiment la
actually see that.
cohérence dans les contextes
We
sociaux
are questioning the
qui sont
coherence
plus
on the social
difficiles
and cultural
et
level,
aussi la cohérence
and
verticale
also
de
this
nos
vertical
coopérations
coherence,
internationales.
whether that be local,
Enfin,
national,
enjeu
or
lié à
regional.
l'approche
Finally,
collaborative et
the challenges
intergouvernementale.
connected
Alors,
to
le
this
chef de
collaborative approach.
l'OMS, le docteur Tedros,
Dr.
répète
Tedros of the
ce qui commence et
WHO
ce qui
repeated
finit dans la
that
communauté
epidemics are
et doivent
starting and
être
finishing in
en première
communities. So they
priorité
have to be the number one
préparation.
priority in terms of
Pour
preparation.
l'OMS, la gouvernance
For the
de la
WHO,
diplomatie sanitaire
we
avec
need
une
governance
représentation des
based on
communautés,
proof.
y compris au niveau de décision, elle est basée sur des preuves.
These
Et
decisions have to be
il promeut,
proof-based.
l'OMS promeut donc
And
une
the
approche
WHO is
multisectorielle et inclusive en associant la
promoting a
société civile.
multi-sectorial and inclusive approach together with
Alors, c'est
the
la dernière diapo.
civil society. This is my
Début de
final
la semaine, le 9
um,
mardi, il y a eu le
slide here.
troisième forum
At the beginning of the week, Monday and Tuesday, there was the third
recherche
forum of
qui
the
définit
Research and Development Group
les feuilles de
defining
route pour
the blueprint for the
prévenir le mieux dans
WHO. The
l'appréhension
first took
épidémique de
place
Covid
when
et
COVID was first
l'adaptation
declared,
à
and then
cette épidémie.
18 months after that,
Alors,
and
j'ai
this was
retenu
the third.
quelques priorités qui nous
I have
concernent,
listed a number of priorities
celles
from that here on the
qui nous
slide,
concernent particulièrement.
and these ones that
D'abord,
concern us
il faut
particularly.
préciser les thèmes et les
We have to
questions à aborder.
be precise on the
Ça, c'est
themes
la
and questions to look
préparation
at, especially when it
pendant la
comes to
période
the
de
preparation phase.
l'adaptation, mais aussi
This could be
pendant
during
le
the preparation
processus, en
period, but
observant,
also during the
en
process
analysant
itself
les dispositifs de préparation au sud
by
et au nord.
analyzing the preparation
On
in
devra
place both
préparer
in the
la
south
recherche
and the north.
appliquée
We
pendant
need
la
to
crise.
prepare research
Alors en
to be
amont,
carried
il
out
faudra
during the crisis
anticiper
itself.
les aspects administratifs, la
We need to
répartition des
anticipate the
politiques,
administrative aspects, the
régulation, méthodes et
ethical
organisation.
authorizations, methods and
Éventuellement
organization, etc.
proposer
We also
des
have to
protocoles génériques
propose
qui seront adaptés
generic
au niveau de
protocol
la
that
crise.
are correctly adapted.
Ensuite, il faut développer des recherches
We need to
inter et
develop inter or
transdisciplinaires et les
transdisciplinary
recherches
research
participatives.
units and
Il
participative
faudrait aussi
research as well. We also
intégrer
need
l'approche One
to
Health, santé
integrate
humaine,
the One Health
santé
approach,
environnementale,
whether that be
pour la recherche
environmental or
sur
animal
les
health,
épidémiques
concerning
infectieuses
research
de
on
résistance
crises. It
microbienne.
could be concerning
Développer des recherches qui
antimicrobe
favorisent la
or
construction sociale
zoonoses.
et convergence, sachant que la
The next
confiance est
point,
difficile
developing research
à construire en phase de
which
crise.
favors social
Il faut donc
construction
étudier
during
ces
the preparation
différents
and
aspects
during the
à la
crisis
phase de préparation
itself.
de crise. Préciser les effets de
We need to
l'effacement des
specify the
recherches entre crise
effects
d'urgence et
of this
développement, renforcement de
blurring
résilience.
between the distinction between
Les
crisis and
épidémies
emergency,
sont plus fréquentes et
given that epidemics
globalisées.
are more frequent and more
Et enfin,
globalized. And
dépasser les
finally, we need to
inégalités structurelles
go beyond
existantes
structural inequalities persistent
qu'on va appeler
in,
épistémiques dans la production de connaissances scientifiques.
in particular
Donc,
for the
vaste
production of
programme
scientific
j'ai traversé à toute
knowledge.
vitesse. Je vous remercie pour votre attention.
I went through that as quickly as possible, and as you saw, thank you very much for listening. Thank you very much, Alice. There's an important point here. Do we capitalize or not the experience and knowledge from an epidemic or not? Whether we are analyst or researcher or not? This is very interesting. One point, you spoke about the fear that was surrounding Ebola, but the same fear was not around COVID. I think that, that may be in Africa, but in France, but I think there was that fear of COVID, like there was the fear of Ebola in Africa. So I think it's the fact that there was no epidemic before that, or recently before that. People have forgotten what it was like, or maybe didn't know what it was like. Many thanks. Let's move on to the next speaker. I'd like to take this opportunity to give you some statistics, just a continuity what Alice has said. We have supported around 33 research programs in 12 countries in the field. The objective for us really is to contribute to being more efficient in the field, to have better healthcare, better practices, whether they be physical or psychological. So concerning epidemics, the more we look at different situations, the more we connect one phenomena to another. We looked at the re-emergence of rabies, not rabies, the plague in Madagascar. That's one example. Malaria as well. But what is interesting in a number of countries is when we look at overseas places of France, access to cancer treatment is not the same as in mainland France. We have the questions of aging too to look at. But what Alice was saying, there is this challenge for civil society and research. Well, we are right at the heart of what is needed. We can see just how difficult it is during the COVID pandemic. We realized very quickly that we simply had to do something. And so we managed to put in place research units during the crisis. But what did we do? All the networks that you saw were very important. On one hand, we were connected to the WHO directive and their blueprints. We worked with our colleagues from the Pasteur Institute. We decided to work on the volunteer aspect of the communities. Their volunteers were mobilized around the world. What really interested us is that we were able to carry out this work. And this was great practice for us, whether they be legal, ethical, administrative, and these are important points of any structure. Why? Because we had pre-existing structures like following on from Ebola. The Western Africa response to COVID was much better. That really was wonderful to see. The work of the foundation is clear. It's really necessary to underline that the Red Cross movement was a real precursor when it comes to having an international view of health. This is what Professor Mette said this morning for those who weren't there.
Aux côtés du CICR, quand la Ligue a été créée en 1919 lors d'une conférence médicale.
When things were created in 1919, the question of world governance of health was raised. This is something that didn't exist back in those days.
Il y avait cette question aussi de la santé, de gouvernance de la santé.
There was this question of governance of health.
Aussi les comités d'hygiène, et qu'en fait tout ça aussi a été au niveau, si on prend un point de vue un peu plus surplombant sur le point de vue des acteurs et de la gouvernance, quelque chose entre les guerres qui a beaucoup bougé, qui était extrêmement intéressant, puisque un acteur pouvait pas tout faire, être en même temps sur le terrain, en même temps s'occuper de gouvernance et de régulation, et en fait ça a été beaucoup d'interactions qui sont fascinantes.
There's a lot of interaction, which was very interesting. Historians are continuing to look at that between the beginning of the WHO and the period after the war, and they're trying to find out what each of their roles were back then.
On n'en parle plus d'aujourd'hui, mais l'entre-deux-guerres, c'était les maladies vénériennes qui occupaient beaucoup les sociétés et sur laquelle, par exemple, la Ligue.
There was a lot of venereal diseases that were affecting society back then.
En reprenant l'intervention d'Anicet ce matin,
following on from Anicet's presentation this morning, the trajectory is important to see where we are just today, where we've come since those early days back in the past up to today right now. And this trajectory is very interesting to continue to look on every level. I'd like to come back to the next speaker. Let's move on to Aude Sturma, who we know very well. Aude, you are a doctor of sociology. In 2013, your thesis was looking at water treatment in Mayotte, studying at the University of Toulouse.
Les organisations sociales ou l'organisation sociale et les pouvoirs politiques locaux en lien avec le système institutionnel. Alors, vos expériences dans l'océan Indien vous ont conduit à analyser le lien entre gouvernance locale de l'eau et la précarité sanitaire, des sujets ô combien d'actualité. Avec la Fondation, vous avez conduit une recherche qui a examiné la gestion sociale de l'eau dans une commune à Mayotte, où la pollution de l'eau a entraîné une crise sanitaire avec des cas récurrents de fièvre typhoïde. On va se décentrer aussi sur ces territoires et voir comment finalement la question de l'eau peut nous amener et nous connecter
This
aux
is
sciences
an
et aux sujets
introduction to
contemporains.
Odsjama, in particular the importance of water in the island of Mayotte.
Bonjour. Merci pour cette introduction.
Hello,
C'est vrai
many
que
thanks
moi,
for
mon
that
travail se
introduction.
situe plutôt en amont des épidémies,
The work that I
sur la
do is really
prévention sur
upstream
l'épidémie de
for
Covid
epidemics, even though I
à
do have a
Mayotte.
slide about COVID to
Et
talk
je
about
vais
concerning
vous parler en
Mayotte.
fait des stratégies
So I'm going to be talking to
d'adaptation
you
pour les
about the
personnes
adaptation
vulnérables
strategies for the
face à
vulnerable
l'épidémie.
populations. Let's move on to the next slide, please.
Quelques chiffres quand même
Just a few
illustrer un
numbers
peu la situation de Mayotte. Mayotte, c'est
to give you an overview of
350
the
000
island of
habitants,
Mayotte,
dont la moitié est
300,000
d'origine étrangère.
inhabitants.
Et sur
Half
cette
are from
moitié, il y a la
overseas.
moitié qui est
Half
en
of that,
situation irrégulière.
50%,
Et
are
donc, on parle de
those who do
milliers
not have
de
official
personnes
papers.
qui
So we're
passent sous
talking
le
about
radar, en fait,
thousands of
des
people who are under
dispositifs de soins.
the radar of healthcare
De manière
on
globale,
the
le
island.
revenu moyen est 3 fois inférieur
Their
à la
revenue
France.
is 3 times
Parce
less
qu'en
than the
France,
average of
c'est un
France,
droit commun, avec un
which is
potentiel
unusual for a French department,
d'exigence
of course.
rurale forte pour l'accès
We
à
have
l'eau et l'assainissement.
75% of the
Seulement
population who live
5% des
under
Mahorais ont accès
the
à un assainissement
poverty
collectif.
threshold.
C'est
Uh, a
10%
very
qui ont
small
accès à
number of
l'eau.
people have access
Les
to
habitats
good
en
water.
dur, c'est
Some
à
don't have
peu
access
près
to any water at
8%.
all.
Pour les habitants en tôle, c'est plus de 60% qui n'ont pas
8,
accès à l'eau courante.
60% do not have access to
De
running
fait,
water.
ça entraîne un enjeu sanitaire fort. Et sur l'île, il y a effectivement plusieurs
So this
foyers d'épidémie de
creates
Covid. Avec une
a number
calamité
of
exceptionnelle de
typhoid
l'eau, puisque
fever
le premier pic de
outbreaks. We
l'eau
have
date de 2017.
water
Je vais vous parler
droughts.
évidemment
The first one was back in
de la situation
2017,
actuelle.
and of course I will be talking to you about the current situation right now.
Première stratégie pour ceux qui ont accès à l'eau, qui ont accès à un compteur,
So the first strategy for those who
solidarité
do have
civile, partage
access,
de compteur.
there is
Comme vous pouvez
considerable
voir sur la photo,
solidarity. You can see in the
ça
photograph
n'a
here,
l'effet d'augmenter le prix au mètre
but
cube
that
d'eau,
only
puisque
serves
le
to
tarif de
raise
l'eau à
the
Mayotte est
price
progressif, de fait
of
que
water.
moins on consomme
The cost of
d'eau,
water
plus le
in
prix de l'eau au mètre cube
Mayotte,
est fort. Plus on consomme d'eau, plus le prix au mètre cube
the
s'élève.
more
Ce qui fait,
you
selon mes recherches, une
consume
moyenne
of the
mahoraise
water, the more it costs.
à
The
17%,
average
mais la
for
population
Mayotte
mahoraise
is
de la température du
17%
budget des ménages, quand on
of
sait qu'on
their
considère au niveau international
monthly
que
bills goes on
les
water.
situations de vulnérabilité économique
And we know that
sont
somebody in
fortement
economic
touchées.
vulnerability, it should be between 3 and
Prochaine
5%,
suivante.
not 17%. Next slide, please.
Pour ceux qui n'ont pas accès à l'eau, plusieurs
For those who don't
stratégies
have
peuvent
access
avoir
to
des
water,
effets.
there are a number of strategies. You can
Certaines
go
secondes
to
sont elles
the
aussi
fountain
retenues
here,
avec
which
des
you
quotas
pay.
suffisants.
There are 90
Ça
of
ne
these
déplace
places on the island.
mais ça pose la question de comment on se déplace quand on n'a pas de papier, qu'on a
But
peur de se faire arrêter
how
par la
can
police
you
judiciaire.
get to these places if you don't have papers? Because you're
Ça pose
afraid of
aussi
being
la
stopped
question
by
du
the police.
transport et du
This
stockage de
answers
l'eau.
the question about transporting the water and storing it
D'autres
as well, if
situations
it's a long way
ont
from where you
aussi
are.
la possibilité de se
Other
rabattre sur
situations
des
are, of course,
politiques
the
de
possibilities
filtration, de
of simply
protection,
taking water from the
des
river.
puits et
3%
des
of
eaux
people
usées
do that,
courantes qui
from wells as
sont,
well.
selon l'ARS et selon des
But
résultats d'études
according
qui ont été
to
faits,
the regional health
très polluées avec la
agency,
présence de
they are
métaux.
very, very polluted and full of pathogens.
Durant la recherche qui a été soutenue notamment par la Fondation
Following the
Croix-Rouge,
research
dans ce
supported by the Red
contexte, en
Cross
fait,
movement, in this
certaines autorités
context,
se posaient la
we can
question
see that the actors, the health
pourquoi
actors, are
ces
asking the following
populations
question:
vulnérables
why do these vulnerable
ne
populations
manifestaient pas
have to?
manifestement
Why are
plus.
they not
Elles se plaignaient pas.
saying?
Et donc, avec derrière
The question was
une
saying,
hypothèse
why were they
d'équilibre
not
mise en
complaining
œuvre qui était de
sufficiently?
dire peut-être
So a
qu'il
certain
y a
epidemiologist was saying,
un
well,
système
maybe
immunitaire qui est
they
renforcé.
have an
Et ce qu'a
immunity
montré
system which
la
is
recherche sur
stronger.
l'eau, c'est qu'en fait, il y a plutôt une
And so
habituation
research
à la
was carried
maladie.
out,
C'est-à-dire
and
qu'on
people
s'habitue aux
are getting
symptômes,
used to the
on devient
symptoms
vieilli
of the
comme
disease, not
des gens,
necessarily the
c'était
disease
normal,
itself.
c'était
So people
banal
were just
d'avoir deux, trois
saying it was
fois
banal
par
to
mois
have
des symptômes
2 or
de
3 times
diarrhée.
per week symptoms of
Et
diarrhea.
ce qu'il faut bien comprendre aussi, c'est la façon dont on va hiérarchiser ces risques. Quand on est en
And
situation
it's interesting to
sécuritaire,
see how you
évidemment, l'accès
how
à
you
l'eau
prioritize this risk.
de qualité,
Access
elle est
to
reléguée
quality water is
après
down to
les
a
questions de
low
survie,
priority
les
after
questions
the
de
difficult
déplacement.
questions of survival and
Ce qui est mis
transport.
en avant aussi, c'était l'impossibilité de répondre aux mesures d'hygiène comme les messages qui étaient passés en ARS, faire bouillir l'eau. Quand on sait que
We also
l'hygiène
wanted
de vie à
to
Mayotte, c'est
share
un geste
some
symbolique et qu'on peut quantifier en millions par mois,
messages one being to boil the water. Some people don't want to use up the gas to boil the water, so they would prefer to spend the money on big bottles of water from the supermarket, which is very expensive indeed. The first symptom of typhoid fever is fever, of course.
C'était un petit peu la doctrine des acteurs de santé qui était de dire il faut passer par la santé communautaire, sans que finalement, en plus, la santé communautaire elle soit vraiment définie, notamment en ARS. Et ce qui a été mis en avant, c'est que dans ces communautés-là, il fallait
What we can see in these communities
des communautés qui étaient stabilisées.
Is that there are certain communities who are stabilized. The situation is very formal.
Un service public sur ces communautés qui étaient plutôt fragiles. Par ailleurs, Alice, tu l'as mentionné tout à l'heure, le rôle du relais communautaire bénévole en situation irrégulière, et ce rôle-là de relais, ça l'expose, et donc ça le soumet potentiellement à des conflits au sein de sa communauté, à des jalousies.
And as a consequence, they might face jealousy or conflicts within the communities. So these community-based relays had to be delicately handled. That's why we supported these relays with local NGOs and I clearly identified organizations. I also wanted to mention experience-based knowledge and intermediaries. Comparing the situation with Toulouse and Lille in mainland France, where we also had some water shortages. The local authorities complained actively in order to have water access facilities. And in Mayotte region, what happened is that they got water pipelines installed, like tap water. And this facility was implemented thanks to what we call marginal intermediaries, who are important cornerstones of the humanitarian action. They have been working within the local context for a while, and they were strong enough to have their voice heard and ask for enhanced solidarity, NGO mobilization with clear identification of vulnerable communities. So they could put in place these intermediaries with water facilities called as water pipes, water taps, as you can see on the picture here. And these low-income population would have access to water taps like this on the picture, thanks to this collaborative work, including intermediaries. The main question is whether this health-related crisis is sustainable or not, because we have faced this situation for 2 to 3 years now. Currently, they are facing 54 hours of water shortage, and during 4 hours, water is not drinkable, is not consumable. That means they only have access to drinkable water for 10 hours a day, which has led me to a very complicated position, because the more we open up to populations, the more we can integrate communities. However, this principle is not working in Mayotte, and this impedes NGOs' action. You can see on the picture here in October 2023, in Mayotte, one particular NGO trained local population for cleaning hands, and there was no water available. The second picture shows a huge amount of buckets which are left empty because there was no water. Another picture shows a banga, like a local local shacks neighborhood, where you can see a makeshift installation for water access. And these situations are very regular. The local French health agency has been repeating thousands of times how to clean hands, how to wash hands, how to proceed with hygiene protocols. However, there is no water. That's the fact. So local populations can't even carry out these protocols. And we also see a lack of capitalization. Thank you. We will move forward with Firmin Croix contribution, who is an anthropologist and lecturer at the Alassane Ouattara University in Bouaké, Côte d'Ivoire. And his presentation is entitled From Bouaké, Côte d'Ivoire to Marseille, mainland France, sharing his thoughts on funeral rites. The originality of this work is to work on funeral rites as a response to epidemics. This is something that was massively ignored during COVID-19. However, it has a major impact on communities because it directly deals with death, visibility, and corpse handling. I'm not talking about social media or media coverage. I'm talking about what happened in real life and to what extent death and corpses have been completely ignored.
Laurent.
Thank you very much. Thank you, Laurent.
On a pour cette habitude de croiser les regards, mais là, je vais essayer de...
We usually cross insights and perspectives. However, I would like to share my insight from Global South to Global North. Can I have the next slide, please? Before this global epidemic context, we used to use words like de-ritualization, desocialization, denial of death, savage death. These were the words that were used in modern Western societies, where we tended to lose cultural and human values. And on the other side, we can still face societies where death is highly ritualized with collective protocols and ceremonies where traditions are enhanced as cultural values. What we saw during the EVD epidemic in Africa is biosecurity of funeral rites based on new Western standards that were imposed on Global South societies. So we saw a kind of perversion or a denial of cultural traditions. And then COVID-19 epidemic happened, and it reminded us that in Western societies, the relationship with death and rights hasn't completely disappeared because the demand for funeral rites increased during COVID-19 epidemic. And this emerging demand was seen as a moral disaster. This is why I wanted to share with you my experience, because during the COVID-19 pandemic, I spent 6 months at the European hospital in Côte d'Ivoire, and this helped me to analyze and to see how things worked. Next slide, please. So first thing first, I started to work on funeral rites with the Ebola virus disease epidemic happening in West Africa. So my first project was called Ebola in Côte d'Ivoire. And we saw funeral rites were seen as hotspots. And some measures were implemented in order to avoid handling corpses. However, we saw that those measures were not respected. So we worked in collaboration with UNESCO Bioethic Department to analyze more deeply funeral rites in Côte d'Ivoire. I'm not going into the details, but what we could see is to categorize and to list the different occasions, what we call contact occasions, and funeral duties. So in 2019, I got a grant which allowed me to work on this phase 2. And this has led to the COMESCOV program that happened in 2019, right at the same time as the COVID-19 outbreak. So I was lucky, if we may say, to be at the right time at the right place, so I could lead a new program on death handling and ritual knowledge. So if we compare Global South and Global North funeral rites, there is one common element, is the place, or the space occupied by families and relatives. And this was visible in both sides, right throughout the disease, but also through the death, right? We saw that extraordinary death would imply specific proceedings. We could see also that funeral rites had to be adjusted depending on whether it happened at the hospital or in families, and this would lead to different social interactions. Everywhere in Global South and Global North, the social interaction change around death and funeral rites. And there is a need to maintain the link within the family and within the victim, and with the victim. In order to accompany in a very respectful and comprehensive way, in order to build what we call a social death, or culturally or socially acceptable death. And as soon as you can't maintain this link, then the death would be considered as incomplete. Also, we could see that you may choose the proper rite depending on the situation. And so you have, say, a choice between different options based on biosecurity measures. It is important to bear in mind context. The dignity concept is a cultural concept. Who is handling the corpse? Who is announcing the death? All these aspects, especially who is in charge, the person in charge will have an impact on the dignity and the level of dignity of the death.
À l'hôpital, c'est pas les mêmes raisons que quand on est au village. Au village, on dirait
in the event of death happening at the hospital, the funeral rite cannot always be carried out. And in this context, there might be a lack of dignity because we can't complete the whole process. And there is also a social dimension of funeral rites because you basically see hospital and institutions as a tool coming from the authority. So elderly generations do not see these institutions as they have some reservations towards these institutions, and they might see hospitals as social control intermediaries.
Alors que comme j'essaie de montrer, c'est que le rite funéraire, ça commence depuis les premiers signes annonciateurs de la mort.
Funeral rites usually begin as soon as the first symptoms of death happen. So there is a dedicated team to take care of dying people. So there is an overall collaborative work based on a team. However, at the European hospital, it's more difficult to maintain this bond, this continuity of service. It's also important to highlight political risk, institutional risk, and reputation-related risks when it comes to funeral rites. It's also important to bear in mind the case-by-case processes, especially when it comes to emergency situations. The very specific case study was on funeral rites anthropology within emergency contexts. This last slide is simply to thank you all for listening, and also to thank all the organizations which have led this project and which have helped me to go through this analysis at the hospital and in the village. Thank you, Firmin. I think this is a great example of how adaptable we should remain, how we can adjust our emergency responses according to the crisis, but also to the local context. I'm always confused with the word resilience because I can't really name any society which is not resilient. Societies are by definition resilient, according to me. Except when we talk about very specific situations like Sarajevo back in the days, which could get back to the previous condition. But it is a very rare situation. To me, by definition, societies are resilient. Thank you, Laurent. And to complement your comment, I would like to enhance the power of networks. Here, there's a clear visibility on collaborative work. As far as I'm concerned, when I worked on Ebola, all the work that was done before was used again during COVID-19 epidemic. We were fully integrated, and that was a major shift. Omar Abu Samra will speak about it further on as a director of the World Disaster Preparedness Center. He will be able to explain the different resources that could be used during a COVID-19 epidemic. And we, at the Red Cross level, we were in the front line, if I may say, to put all these people into collaboration as a network. And this is a crucial part of the efficiency of the response. So I will move forward to Vincent Falguero, who is the head of technical expertise at the French Red Cross. He shared his time during clinic studies and contribution of international humanitarian aid, especially when it comes to epidemics happening in complex situations. You were an active contributor of the Red Cross mechanism during COVID-19 emergency response. And you were also actively contributing to the Ebola response a few years ago. So we can see through your experience the link between the two as well. Please, Vincent. Thank you all. My presentation might be a bit different from what we've seen so far, because I wanted to enhance how we could use the international humanitarian aid to the national French response in the COVID-19 context.
C'est pas grave, je vais commencer le temps que la présentation arrive. Peut-être en quelques mots, l'expertise santé de la Croix-Rouge française.
To give you a few words of introduction, at the technical expertise department of the French Red Cross, we operate mainly in French-speaking African countries, but also in Indian Ocean, South Pacific Ocean and Caribbean areas, as well as Middle East, but we are now focusing more on Europe because of the Ukraine conflict. As far as the Red Cross is concerned, the French Red Cross is concerned, we have focused on more recently on disaster management and health issues.
Plus pour les autres, moi je la connais du coup.
Toi, tu sais, il n'y a pas de texte, donc tu as besoin.
Non, non, ça va, merci. Du coup, en termes d'expertise santé, on travaille principalement
As part as the health expertise, we work on primary services and food systems, sexual education and prevention, specifically on gender-based violence. Third pillar is capacity building, especially when it comes to training on health issues. Some of you are present today here with us. And last but not least, information systems and information dissemination. So the very first focus was on infectious and epidemic episodes. Some of you might have been there back in the day when we started working on malaria, Ebola, and other infectious diseases. We mentioned Ebola, but we also mentioned other diseases in Mayotte, for example, as well as mosquito-borne diseases like chikungunya, Zika.
Voilà, diapo suivante, merci. Voilà, sur la question des épidémies, puisque c'est le sujet qui nous occupe aujourd'hui.
As we are interested in epidemics today, our main expertise is based on clinical collaboration. We have worked specifically on public health issues, especially in emergency situations. We didn't want to work only with affected people, but also to work upstream with early actions based on detection, detection schemes, which would allow us to detect early abnormal scenarios in order to trigger early responses, early actions, and as a consequence to reduce their consequences. We also wanted to work upfront to make sure that we have relevant information to know where to operate, where to act, and to concentrate our efforts in dedicated zones. We worked also with intermediaries within the communities, which would help us to, which would be used as relays, because we knew that the epidemic would spread out very quickly. So the first thing first was to work within the communities. We also worked with health systems, national systems, to be ready, to make sure that health personnel, health professionals would be on the front line and would be as trained would be trained efficiently and would be as ready as possible. So my presentation wanted to share with you how we could use international humanitarian schemes to prepare our response in April 2020 when the COVID-19 outbreak happened. We all remember that. Alice Desclos mentioned it earlier. COVID-19 outbreak probably didn't affect only vulnerable populations, but the overall population in France, at least. And it had impact on social, medical fields. The very first people to be affected were health professionals. And this was particularly the case for COVID-19 because they were in the front line of the outbreak. So we faced this very complicated situation where we needed to maintain activities and at the same time dealing with emergency response. The usual needs wouldn't be stopped because of lockdown. There were a continuity of service to be provided. So how could we translate international schemes into national response? Could we share the presentation? Or I can't see it here. I'm just trying to have the presentation on screen because I added many interesting photos I wanted to share with you. Sorry, I sent it pretty late. So how did we translate this expertise into national response?
Notamment au décours d'Ebola, puisque c'était évoqué tout à l'heure par Virginie. On a pu faire un guide opérationnel, par exemple, pour pouvoir décrire nos interventions et pouvoir les réutiliser rapidement si nécessaire. On a travaillé avec la fondation.
We worked together with the foundation on this, specifically on the research areas during Ebola, but also in other occasions since that. This has enabled us to be able to really capitalize on the situation in order to better understand our interventions and also to understand the needs. We can jump 2 slides now, I think, to catch up. And now we have another technical problem on how to change pages. Next page, please. Here you can see the map. This will help you to revise your geography a little bit. Let's move on. One more and another one. There's information to say that we had a COVID pandemic. So the objective on the left here, you can see the international expertise. How can we use them on an international level? How can we capitalize on this? But we're in a situation which is a little bit more complicated. We're in a situation of urgency. We don't have time to think. And we're not talking about the same activities here. I'm going to look at I'm going to put the spotlight on a number of these different examples. Next slide. So how did we do this? Well, something very important happened from the very beginning. We realized that here we are facing a problem of great amplitude, one that will last. And we need to get organized in order to face this. So we created a team whose job was to bring together right at the beginning, even before the first lockdown, in fact, to bring together international expertise and national expertise. And we were in the operational center of the Red Cross in order to provide framework and structure to all of the Red Cross activities. I'm going to look at 2 key areas of this. The first was a request from our governance, which I found very relevant at the time, and that was to work as a priority on protecting our staff. That was important. That enabled us to continue to act, to work. So how did that work? We transposed all the expertise over a number of different epidemics, COVID, as well as Ebola, Zika, etc. And that enabled us to really put the right structure to maintain a team, of course a limited team, but at least they were there and we kept our activities going. And the idea was to limit the impact of the epidemic on the Red Cross, whether they are paid permanent staff or volunteers. Some examples here. We put in place a document which enabled us to give the clear guidelines on how to protect ourselves. When should we wear a mask? When shouldn't we? When do we need to wear gloves? When not? And that document was updated frequently. I think there were 20 updates. Every time there was an update, there was a new link, and they would click on that link to make sure that he had the most updated version. So we were able to be very reactive. We created a number of teaching tools. Look at the photograph here at the bottom. Concerning clothing, how do we put on the overalls? How do we wear the PPE? And you can see the comparison between what we did during Ebola, very heavy equipment, compared to COVID. You can see the comparison here. This enabled us to react very quickly. The third point, in place a system of epidemic monitoring within the Red Cross. I'm going to leave that in suspense because it's in the next slide. Fourth point, looking in detail within our unit to look at how we can carry out research activities and recruit a group of researchers in order to follow the crisis in time, enabling us to adapt correctly the message that we were giving out and communicating. Unfortunately, we were not able to meet that last objective. There weren't enough of us to do that. But the foundation was able to carry out a research project with the Pasteur Institute, it was mentioned earlier. And this gave interesting results. We looked at the questionnaire, it was quite interesting. And there were a certain number of elements that were identical between theirs and ours. The next slide, you're going to see an example of the result of the system that we put in place. So this was adapted to the international level. The idea is to spot the areas of France that were most affected in terms of sick people. That's to say, people of our team, so that we could be quickly reactive in providing the necessary support. The idea was also to understand what was not working in these particular departments in order to ensure that these were better adapted. Look at the 28th of May here, that's just a month and a half after the outbreak. 72 people in our teams were affected, and that enabled us to see the regions which were the most impacted by COVID. Beyond the maps, we asked questions about those who were infected, and the tool enabled us to know that on the 20th of May, that among those infected, we had 76% of those who were aware of the guidelines, protection guidelines, and that enabled us to say, well, there are 25% of the people who still didn't know. 84% thought they had respected the distancing rules. These people were convinced they had, but maybe they hadn't been efficient. That also enabled us to gradually adapt the efforts of raising awareness among our teams. What was reassuring there was that 94% of the people who were affected were able to benefit from health care. They were not abandoned, but that meant that 6% did require individual health care from our sentence. Next slide, please. Next page is adapting this data, and we stayed very pragmatic here. We put in place a page of resources. This is just one example here. The page is very long. Resources here that had been approved not necessarily written by the Red Cross.
Collaboration avec la Fédération internationale, par exemple, ou d'autres sociétés nationales, ou d'autres acteurs, tout simplement. On avait quelques-uns de l'OMS, de MSF.
We also had information from Doctors Without Borders and also from WHO.
Recherche, mais qui puissent avoir un endroit où ils ont accès à des ressources validées. On a également réalisé différents webinaires régulièrement.
We carried out a number of webinars as well that were adapted to the feedback that we'd had from the field.
On va dire la transmission de l'expertise. Diapositive suivante.
Next slide, please.
Donc, en termes de résultats, je pense.
In terms of results, and this is the end of my presentation, I think. This enabled us to maintain actions, and that's important, because for those who were present, but there weren't many stakeholders at work. When we hit lockdown, a lot of people stayed at home, a lot of places closed because they wanted to protect their staff. And this enabled us to close down certain activities which we thought were not dispensable and maintain actions that were vital to continue. Specifically about food parcels, one of the Red Cross, one of the few organizations who were able to carry on these food parcels. We also put in place new activities. People who couldn't leave their homes, for example, couldn't go shopping. So that's just one example of something we were able to continue to do on a national level. And in a final second stage, we were able to quickly put in place actions that we were used to doing already internationally. Vaccination, for example. It wasn't easy to put in place, but we were able to manage very large vaccination centers across France, and we were an important stakeholder within this process. We carried out a number of calculations to work out that we had contributed to 12% of the French population. That's quite significant for a stakeholder who can traditionally vaccinate. So I'm going to come to the end of my presentation there. We can open questions to the floor if anybody has any questions or comments. If you could present yourself as well. Anthropologist at the IRD. I have several questions. I'll try to synthesize here. Let's start off with Vincent's presentation. How expertise was mobilized. Just an example on what was mentioned. How, during an epidemic, can we put in place research quickly? Just an example. There's a certain number of us in the room who have expertise in anthropology for Ebola, and when there were the centers in France, we were lucky, thanks to the IRD, to have financing anthropologists who were there. But unfortunately, they were not allowed to access the centers. There was a formal ban on them entering. So despite the invitation, they were not able to enter. This wouldn't have happened in in a country in the southern hemisphere. So I think we can learn from experiences from the south and put them in place in the north. That's the first point. Question about resilience. Lots of anthropologists share my opinion concerning resilience. If people say, well, the countries are now resilient, and that sometimes stops funding. So that's why we're wary of the term resilient. So resilience is a good way for politicians to say, well, if they are resilient, then we don't need to give them any money or aid. A question to you, Firmin, about the mass deaths that took place in Italy. It's comparable with what we saw with Guinea for Ebola.
Reconstruction, en revivre après survivre, on a une association qui a déposé 650 plaintes devant le tribunal de Rome et le tribunal de Bergame, avec mise en examen de 19 personnalités politiques en Italie.
19 Italian politicians were actually taken to court due to the mismanagement of that COVID outbreak there. And finally, I've got a lot of questions about this transdisciplinary aspect that you spoke of.
Et la question de la transdisciplinarité, moi j'ai une question déjà sur comment les gens arrivent à déterminer que c'est un foyer de fièvre typhoïde, avec quel outil diagnostique.
So a question about Mayotte, how can you identify that a household is attacked by typhoid fever?
Et puis la question qu'on a beaucoup rencontrée en Afrique de l'Ouest, on est plusieurs.
And a question we saw a lot in West Africa, it concerns that we know 80% of diarrhea is from viruses and not from bacteria. So that means if you boil the water, that's not sufficient because you can still catch diarrhea from other people. Can you be faster than the anthropologist that just spoke? The interpreters would like to disagree with that. My question is to Vincent. In 2015-16, I was able to carry out a project in Guinea for Ebola. And when we did our retex, I was at the center of Red Cross when we did that, because I remember in my report, I mentioned certain aspects in the field that were not appreciated by certain people in the Red Cross. Things have changed a lot since then. So my question is about the coordination. We've worked a lot in the field. We can see that there's been a problem within the Red Cross. It's not a question of training.
On a fait intervenir les Épruses, on a fait intervenir. En fait, c'était sous le bannière Croix-Rouge officiellement, mais les acteurs du terrain n'étaient pas uniquement Croix-Rouge.
The actors in the field were not only Red Cross, so the coordinators, who was responsible of the Red Cross, was not able to get people to follow his orders because people considered that he wasn't the right person to direct them. So there was a certain cacophony within the coordination, and we saw that in the field. That's the first point. Second point, how do you work with other humanitarian stakeholders?
Que la plupart des organisations humanitaires préféraient les actions qui les mettaient en lumière, qui étaient médiatisées. Les actions qui n'étaient pas médiatisées, donc n'étaient pas, alors qu'elles étaient aussi importantes. Donc on se retrouvait parfois, ils se retrouvaient, eux, moi je suis chercheur, donc j'étais un peu en retrait. Les humanitaires se retrouvaient parfois sur un même terrain pour les mêmes activités dans la même communauté. Du coup, ça a développé tout ce qu'il y a eu autour de business et Ebola business, parce que la population ne comprenait pas comment 2-3 organisations humanitaires qui étaient censées coordonner une action se retrouvent sur le même terrain pour ces mêmes actions. Donc, à ce niveau-là, comment vous gérez la coordination?
So how do you manage the coordination yourself when it comes to working with other humanitarian structures? So that's the end of my question. Okay, we think we're going to stop with the questions. I know, let's have another question. I am a doctor. I'll be going. Alice, you mentioned this fear of the populations. We saw this in France. How do public authorities react to this? Can you make a comparison between the reaction of the authorities to Ebola and those in France for COVID? Can you compare the two, please? So each one of you can respond to the different questions and then conclude. Thank you for those questions.
expliqué d'une certaine façon mes idées de conclusion, donc c'est parfait. Comment on va faire la conclusion combinée, c'est impeccable. Sur les questions de comment est-ce qu'on mène
So the question about how can we carry out a research project during an emergency, well, that's the
justement, moi, je voulais un peu poser ça
part of the matter.
comme prochaine étape en fait de
I would say that
réflexion.
this is the next
Aujourd'hui, quand on
stage and area on which to work.
situation, on se prépare,
When we have other different
on
types of
met en œuvre
situation,
un peu,
we
on improvise.
prepare
Donc, on met
upstream.
en place
We don't
une phase de
improvise.
préparation,
We put in
on
place
forme les gens,
our
on
preparation, our
fournit le matériel
contingency
nécessaire,
plans,
les
our
finances
training
nécessaires,
programs.
de façon à
We
ce
have
que
the
quand
necessary
le
finance in
matériel dont on a
place
besoin
so
dans
that
un
when
moment,
the
on n'a plus
disaster
qu'à dérouler le plan, on
exists,
va
we
dire.
are
Donc,
ready
forcément, ça se passe jamais
to
comme
roll
prévu,
out
mais
our plan. Of
en
course,
tout cas, on est prêt.
never happens as we
Et je
want,
pense
but
que
in any
sur
case,
les
we
dossiers
are
de
ready.
recherche, finalement, dans ces phases d'urgence, il faudrait peut-être
Concerning
faire la même chose,
research, I think we should do the same thing
avec
to get
les
better
chercheurs,
familiarized with
recherche,
our researchers
pris
upstream,
peut-être
pre-identify key subjects on which we can
et je crois qu'Alice évoquait
concentrate.
une dernière
Alice mentioned that in her
question
last slide.
des autorisations en avance, travailler sur des
Work with financing and authorizations upstream. I think there's always this notion of a different timescale when it comes to research and emergency. That's normal, that's logical. But the two do have to come together, and to do that, they have to be correctly aligned. Work is still necessary on that subject. On the second question, concerning Ebola in Guinea, I think in this research project, which took place back then, I think it was 2016, 2017. Back then, these were the first projects working together in common. It was also my beginnings. I was happy to hear that it wasn't an issue of training because I was working in the training team back then, so I feel a lot better. But on a serious note, I think this is connected with the previous question. People were not necessarily in tune with each other. I think there is another subject, and that's appropriating the research results. So today, this question of research, it's not always relevant for those people working in the field, so we need greater awareness. I think those in the field and researchers have to make the effort to come together to find common ground, to better understand each other. But unfortunately, when we are researchers, and that's not my case, but I do have a PhD in this field. I think when you are a researcher, you'd like to talk about your subject. You'd like to share so that it can be used in the field, of course. I can just add something in 1 second. We made the error by not working together. We thought the research was on one side and the field was on the other, and we really should have brought everyone together, work together, get you to work together. Because for COVID, we were together with our colleagues, also together with Geneva, also with our researchers. We were in discussions with so many different people and teams. It was too confused. And everybody had their role to play there.
Merci. Alors, merci Marie pour la question. Je ne vais pas y répondre moi-même puisque j'ai pas travaillé de manière, j'ai pas d'analyse scientifique sur la France.
I don't have the scientific knowledge necessary to answer this, but I would like to refer to a book called Ethics and Epidemics. Maybe it's not the exact title, but the book analyzed all the different ethical challenges And the main overview shows that we have a health democracy in France, and they question how the WHO positioned themselves. So far, we have highlighted values, ethical values. However, we are shifting more and more, especially the WHO is shifting more and more towards scientific framework to explain the use of health democracy. And to do so, we need qualitative analysis. That means we can question the accuracy and the effectiveness of ethics and whether we should do more to move forward towards health democracy. So it was just one side note to let you know that this is an ongoing debate about ethics and epidemics and access to health services worldwide. You mentioned mass death in Italy, and you raised the question of organizations. If you look at Ebola, COVID-19, and AIDS epidemics, you would see that mainly in Italy, families were mobilized. Families were in the front line to enhance mutual care as far as COVID was concerned. As far as AIDS is concerned, the main actor are organizations, NGOs. And as far as Ebola was concerned, the main relay was treated people, healed people who worked as relays to claim and to put their knowledge into practice and to help others. When we talk about mass death, it's important to categorize because it may vary from one epidemic to another. They all lead to social death, but the process is different. Getting back to the question about surveillance and prevention schemes, I'm not an expert, but as far as Mayotte is concerned, we had, it's not like we acted as spies in Mayotte houses, but we used a surveillance system showing through regional health agencies and AFD institution who worked within the communities to have a physical test and physical evaluation of who was carrying out the recommended protocols. As Virginie mentioned, we usually intervene after the questions are raised, when we have to study or to look at the main challenges, the main supports in order to develop new master degrees, new research fields. However, we would like to be able to act upstream, to be able to translate research outcomes into acts and facts? How can we translate our findings into actions to contribute actively? If I give you an example of the thesis that I wrote, could be used as an example for a concrete approach. These questions are very important because they would help to build bridges between academic research and humanitarian sector. Unfortunately, there's a wide amount of researchers, brilliant PhD students and young doctors who can't really work in the academic field and finally choose to work into research, action and research fields. So I would like to insist on this, on the training of young doctors who should be able to gain technical expertise to make them able to lead projects and to collaborate with international aid stakeholders. It's important to capitalize on research and young doctors so that we don't lose them and we can use their studies to feed our academic research domain.
Extrêmement, c'est de voir qu'il y a tellement de solutions qui sont à portée de main. C'est-à-dire quand on voit vos travaux et quand on voit nos collègues agir sur
What's important here
facile à faire, ça demande un petit peu de ressources, mais c'est pas énorme si on regarde.
Is to make the link between what you guys are doing in your research activities and what we do at the operational level. Solutions are at our reach. The only thing that we need is funding. We are ready as practitioners, if we may say, as operators, to work on how we can improve our activities in the last mile, how we can access necessary fundings to achieve concrete results. How can we knock at public authorities' doors to have more money to do so? Thank you all for these contributions, and thank you to the audience as well for raising questions. Something we can highlight as a conclusion is the link between research and emergency sectors, how we can contribute to emergency responses based on research studies, but also the other way around, in order to have access to relevant information to get ready for the future epidemics, potential epidemics.